Okay, good tip, good tip. So make sure that you ask about that. So I want to start with some of the questions that have come in. So one of them is actually a little bit general, but is IV chemo ever indicated, Dr. Sonpavde, for non-muscle invasive disease?
So the
Can you
short
talk a little bit about that?
Yes. So the short answer is no. So IV chemotherapy, intravenous chemotherapy is only given for cancer invading the muscle or if it's metastatic. For cancer that's not invading the muscle, we give chemotherapy, but intravesically, as we call it, but into the bladder. So no IV chemotherapy yet for cancer not invading the muscle.
And is that because the endothelial lining there, the urothelial lining, does not get everything because it's meant to keep the toxic chemicals inside the bladder? And so it's not getting what goes into your system. Is that why that they don't give it for non-muscle invasive disease?
Right, that's one reason. So the cancer is in the lining of the bladder, the non-muscle invasive cancer. So that's one. So you give the chemotherapy into the bladder. That's a good logical reason. The second reason is that these cancers that are not invading the muscle are not dividing as rapidly as the muscle invasive cancers, and they're not as aggressive. So cancer cells that are not dividing rapidly don't get killed by chemotherapy as well. So it's a paradoxically, chemotherapy needs rapidly dividing cells for it to work. So since these cells are not dividing as rapidly, we think systemic chemotherapy given intravenously, that's probably one reason why it's not as effective.
Okay. This is another question for you, Dr. Sonpavde. What about Taxol in combination with cisplatin? Are there treatments similar for patients with bladder cancer that's diagnosed as adenocarcinoma?
Yeah, so Taxol has been used as a second-line chemotherapy or intravenous chemotherapy for patients where there was growth of cancer after they got the cisplatin-based combination chemotherapy. So that's where it's been used. There was a big phase 3, a randomized study done where they tried to add Taxol on top of the gemcitabine cisplatin chemotherapy. And there was a big study around 630 patients that did not show an improvement in survival. There was trends for improvement in outcomes, but not quite. So it did not make it. That's why we do not routinely add Taxol to the gemcitabine cisplatin when we give that regimen.
Okay. Here's another question. How do you compare the immunotherapy, the immuno-oncology drugs like nivolumab or Keytruda with chemotherapy? Is there a benefit of one over the other?
Right. So the immunotherapy.
How do you as a medical oncologist decide?
Yeah, good question, Stephanie. So immunotherapy, as you know, this is the era of immunotherapy. These drugs work differently. They're boosting your immune cells to fight the cancer. So they're not directly attacking the cancer cell. They're stimulating your immune cell, the lymphocytes, to attack it. So these drugs are unique because the way they work is unique. And secondly, one of the traits of immunotherapy is when they work for a long time. So with chemotherapy, when patients have a response, when the tumor shrinks, it tends to bounce right back in a few months, unfortunately. It does not stay controlled for a long time. But with immunotherapy, drugs like Keytruda, pembrolizumab, atezolizumab, you may have heard some of these names. So these drugs are activating your immune cells. When patients respond, which is not everyone who responds, about a quarter of patients respond. Unfortunately, we wish more patients respond. There is research going on, but the responders have a really long duration of response, which can last even more than 2 years on average.
Great. Okay, good. Don, I have a question for you. You said you were in a clinical trial. What were your thoughts as you were offered that as an option in terms of thinking about a clinical trial? We know that clinical trials can be a viable treatment option for some folks. So what made you decide to be part of that trial?
Well, Two things. The first was I just, listening to my options, I just realized that the immunotherapy was another layer of treatment that sounded like it had a viable benefit for me. And the other is I'm in the medical field, so I know the value of clinical trials. So why not? It might help somebody else in the future.
Okay, yeah. With a clinical trial, Dr. Sonpavde, maybe you can speak about that. You get more regular monitoring than you might in a regular physician's practice if you were just having, say, chemo. So is that a benefit for patients who want to be on a clinical trial?
You could say that. So it's true that patients getting on a clinical trial do get more rigorous monitoring than standard treatment. Now, that's not to say that we don't monitor patients on standard chemotherapy as well or something like that. It just means that when patients get on a trial, these are many times new drugs being tested, in this case, in combination with the chemotherapy that you received. So we do have to pay extra attention than we would for standard chemotherapy because these are new combinations and new drugs being tested. So yes, there is a little bit extra attention for sure.
Okay, good. And again, the same thing, if there are side effects, they can certainly be managed with that extra attention, and patients can always come off of the trial, correct?
That's correct. So patients
if they find that they're having a struggle?
Yes, you're right. So patients can certainly come off trials for if they change their mind, don't want to continue with the trial. Side effects may happen. Immunotherapy has a somewhat different list of side effects. We worry about diarrhea and inflammation in the lungs. Sometimes when the immune system gets boosted, it can attack some of these other organs. Most of these are not life-threatening. We can control them. Some people need steroid pills, prednisone pills, sometimes admission for stronger drugs. But most of these can be controlled quite well with prompt attention to symptoms.
Okay, great. So Donna and Sam, how much involvement did your family members have to be engaged in your treatment because of going to the chemo over a period of weeks? What was the experience from your family members? Can you talk about that?
Donna, you want to talk first?
Sam, I can't hear you. You got to speak up.
Want me to talk first, or Donna?
Go ahead, Sam.
Okay, I'll go ahead. Actually, my family was very involved, and I was, I tell them I'm very blessed on it. I have 2 children, as I say, and they all, each week I went in, each one of them took turns to take me in, and I, other than even the family, it was amazing how many people came to me, good friends, and said, if you need a ride in, Sam, no problem, we're going to take you in, we'll take you in. So I had no problem whatsoever of riding, going in, none whatsoever. Also, by the way, I was in a clinical trial also, for what it's worth. I agreed to go on it.
Okay. Donna, what about you?
So as I mentioned before, I was blessed in the fact that I always had somebody that was bringing me to and from chemo and staying with me while I was receiving it and distracting me. I think it was a great situation for them as well, because they feel as if they had something they could do positive to help, because it's a little, you feel a little helpless with cancer. And so, again, it was a blessing for me because I was never alone and felt quite spoiled. It was great. And then again, it allowed them to be a part of the treatment, really.
Yeah. Excuse me, I mentioned
Dr. Sonpavde, with chemo during a pandemic, how has that changed, that family involvement? What are you seeing at Dana-Farber?
Yeah, we have had a policy where we have had to restrict visitors quite often, but there are situations when we do think a family member or a friend accompanying the patient is good for the patient, and the benefits outweigh the risks in some specific situations like that. So we have made exceptions in many cases like that. But just the state of the epidemic is such that we do have to protect these patients from the pandemic. Of course, now we have the vaccines that are being administered, and that could help alleviate some of the situation. But so basically, it's balancing the risks and benefits. So we have, on a case-by-case basis, allowed visitors to come with patients.
Mm-hmm. Okay, good. Okay. So you just mentioned the vaccine. So what about if somebody is facing chemotherapy as their treatment option? What are your recommendations about when should they get the vaccine? Before they start treatment? Should they take a break in the middle of treatment for their vaccination? Should they put it off? What should they do?
If at all possible.
It's also new.
You're exactly right. So we're still on a learning curve here. But logically, if you can wait safely, you can get the vaccine, first, and wait about 3 or 4 weeks before starting chemotherapy. Now, that's not always possible. In someone with aggressive disease, cancer growing, it's not possible usually to wait 4 or 6 weeks to start chemotherapy. So the situation where this might be possible is post-operative chemotherapy. The bladder has come out for muscle-invasive cancer. Usually we wait 6 to 8 weeks to start chemotherapy. Studies have allowed waiting up to 3 or even 4 months to start chemotherapy. So there is some time there to get the vaccine in. But in the other situation, the neoadjuvant situation, we really don't have 6 weeks to wait for the vaccine to kick in to start the chemotherapy. So in that case, I would say the bladder cancer treatment is more important and more time sensitive. So that's different. In patients with metastatic cancer, again, it depends on the aggressiveness of the cancer. Generally, with the metastatic cancer, you don't want to wait 6 weeks. So what I would suggest in that case is to get the chemotherapy going, get the disease cancer under control. And after 4, 5, 6 cycles, that's how long we like to go. We could take a little bit of a break and do the vaccine.
Mm-hmm. Okay, great. Here's a question about neuropathy. You mentioned that earlier. There's a patient on this call who is 7 years out and they have neuropathy in both feet. Is there anything like a vitamin or any other treatment that might help bring that feeling back or reduce that pain?
Yeah, neuropathy is a tough problem. And this is one of the problems that can persist for many years. Now, the best thing you can do is to prevent neuropathy by reduction in dose and interruptions of chemo when it's going in, when you start seeing the neuropathy appearing. But there are medications to treat patients with neuropathy, duloxetine, Cymbalta, Neurontin. There are many other medications, Lyrica, which might help some patients. We have used topical creams like capsaicin, menthol-containing creams to help with patients who are tingling and numbness in the hands and feet. Exercise, physical activity does help neuropathy. Some patients have gone with some alternative treatments and interventions such as acupuncture. So there are multiple ways of trying to alleviate it, but it can still be a difficult problem. And really, prevention, as they say, an ounce of prevention is better than a pound of cure. So this is a problem which is best prevented because the treatments are can help, but they're not highly effective, in my opinion.
Sure, absolutely. I agree. That's certainly an issue and a concern. So people should definitely bring, as they have signs and symptoms, they should bring them to the attention of their doctors. I think sometimes some patients don't want to bother their doctor, and they think they can handle it and it'll go away, but they should bring these things out so they can be remediated as they're happening, and you can change course a little bit and hopefully prevent some of that damage. So this is wonderful. So anything else? Thank you all so much for sharing. This has been a very, very valuable session. As I said, we're going to have the recording available and online, but any closing remarks? Dr. Sonpavde, you want to start? Anything you want to say to our audience?
Thank you, Stephanie. I think this was a highly informative, session for patients and families facing this cancer. We've come a long way. Always ask your doctor about trials and other issues that you don't fully understand. I can tell you that sometimes a lot of oncologists may also not fully understand. We don't fully understand this disease. So there is a learning curve for everybody. So really we could learn from you as you learn from us. And I think that together we can really do a better job with chemotherapy and other forms of therapy.
Sure, absolutely. So, as you heard from our two patient advocates, chemotherapy wasn't necessarily what you expected it to be, was it, Sam? And so, maybe talk to your doctor. It's not your father's chemotherapy, if you want to think of it that way. Think about, patients that you knew 10 years ago or even 5 years ago. There have been major advances, and there's things that you can do to mediate any kind of side effects. I think that's important to understand. So the field is changing on a regular basis. I see Sam is nodding, and I think Donna agrees too. It's not the same thing that you think about when you hear about chemotherapy, right?
Absolutely.